We'll go over now the radiographic interpretation using the HipScreen app. And again, no disclosures to inform you about. So I've talked about how hip surveillance really has become the standard of care now with our numbered letter in California, and frankly through the hip surveillance pathway, care pathway through the CP Academy. I think there's a swell of interest and commitment to doing this for all children. And we talked about the details of the CP Academy hip surveillance care pathway and the details and how it mirrors many of the existing hip surveillance guidelines that are out there. And so really you can't do wrong choosing from any of the hip surveillance guidelines that are out there, because the subtleties between them is much less important than the vast difference between doing it and not doing it. So all children with cerebral palsy deserve close monitoring for hip surveillance, whether that be via physical exams or risk-stratified x-rays. So this is a group predominantly of therapists. So the real question becomes, what's your role as therapists? Are you improving function, analyzing function, measuring physical exam measures, or are you more like a radiologist reading x-rays? Like, what should you be doing? And hip surveillance has these two twin parts to it. One is a radiographic assessment, but equally important is a clinical assessment that you'll be doing with each visit that a child has to you in the clinic. And so understanding the patterns of referral are also important. So a referral should be made to an orthopedic surgeon or other physician or professional that's familiar with hip surveillance guidelines once the migration percentage is over 30%, if the child is experiencing hip pain, if the level of function has decreased, or the child's hip abduction range of motion has decreased to below 30 degrees, whether measured in flexion or extension. And this is mirrored in the hip surveillance care pathway by the CP Academy. So I wanted to get into a little bit more detail about a resource that I think may help you with doing hip surveillance on a local level, which is the HipScreen app and the companion website, hipscreen.org. And much of this material, and hopefully these videos will soon be on that website too, to give you more information to share with families and to educate yourselves. And so as I spoke about before, we have educational material on hip surveillance that's formatted in a PDF format to include education about how to read x-rays, why hip surveillance is important, how to position and properly obtain a hip x-ray, how to measure level of function as classified by the gross motor function classification system, as well as these various PDFs of the hip surveillance guidelines from around the world, and soon to include the CP care pathway. Right now, the recommendations that are on the HipScreen app very closely mirror a blending of the Australian, British Columbia, and Swedish guidelines. And you can select the child's level, and it'll allow you to quickly see the child's level of function and how often you ought to be obtaining clinical exams and x-rays. And we will modify this soon to mirror the CP Academy recommendations. The Android version is coming soon. We're still in the final processes of getting that launched. It will have some additional features that we hope to bring over to the iPhone version too, including the full descriptions of the GMFCS, the MAX, FMS, and CFCS, which are all various ways to categorize upper extremity function, motor function, and communication function in children with CP. So it'll be a resource that's beyond just hip surveillance. And we'll also include the full guidelines from Australia, British Columbia, and Sweden. That's kind of the full package, as well as links to their website, and also the CP Academy guidelines and website. So that's soon to come, hopefully within the next few months. So let's get into some details about how the migration percentage ruler works, which is probably the most innovative part of this app. So as I spoke to you before, the migration percentage is the percentage of the ball that's outside of the socket. So but to really arrive at that percentage, you need to better understand the radiographic landmarks. So I'd like to go through the radiographic landmarks so that we're all speaking the same language. Okay? So I talked about the triradiate cartilage before. The triradiate cartilage on a standard X-ray appears as a dark line in the center of the socket. These are the pelvic iliac wings. And then the ischial tuberosity is also part of the pelvis. And then the obturator foramen is the circle that you see down below. The acetabular sourcile is the weight-bearing dome of the acetabulum. And the femoral head ossific nucleus, as I described earlier, is where is the sort of growth center of the proximal femur. So let's go into each of these in more detail. So here I've highlighted the femoral head ossific nucleus with dotted lines. Okay? And the femoral neck and the metaphysis are outlined in the white dotted lines. And it's very important to note that the migration percentage is measured off of the femoral head ossific nucleus. So I've shown here with red arrows the borders of the ossific nucleus. You'll notice that that's different from the borders of the femoral neck width. Okay, and that's a trip up that many people have when they're analyzing these X-rays. And I'll emphasize that again when we go through some subsequent slides here. The acetabulum is the complete area that is contacting the femoral head, going from the sourcile and the acetabular edge all the way down to close to the femoral neck. And it is this red edge of the acetabulum that is our marker for the lateral aspect, or the part from which everything outside of that constitutes outside of the socket. Okay, I mentioned the acetabular sourcile above. It's the sourcile or eyebrow in French. Looks like a well-manicured eyebrow, as you can see here, which is a radiodense line that is the weight-bearing dome. Okay? And the acetabular teardrop is another part of the acetabulum here, not on the weight-bearing surface, but another important landmark because the shape and structure of the teardrop corresponds to the amount of concentric forces that are put across it. So it develops its normal concave appearance when the femoral head is pressing up against it. And it starts to become more convex and a larger width and more V-shaped as the femoral head spends less time in the acetabulum. I'll show you that on some subsequent slides. The bottom aspect of this triradiate cartilage, the bottom aspect of this teardrop is an important landmark for establishing the horizontal when you can't see the triradiate cartilage well. And I'll describe that when we're talking about leveling the pelvis to draw the lines. Your triradiate cartilage is the black area here in between the two aspects of the pelvis, with the red arrow showing you the edge of that triradiate cartilage, which is the most common place at which you would start one of the dots to level the pelvis for your first step in measuring the migration percentage, which I'll describe. So looking at the overall anatomy here, we have the pelvic wings with the superior aspect of the pelvic wings with the red arrows. We have the ischial tuberosities here below. The most inferior aspect of the ischial tuberosities are also marked with the red arrows. Those are also important landmarks. And I sort of threw out the term medial and lateral. That's a very easy term for a therapist to understand. But if you don't have a medical background, medial refers to the middle of the body, lateral away from the middle of the body. So when you start talking about specific landmarks on an X-ray, the medial of one may be lateral to the medial of another. Okay, so look over here. We have the medial aspect of the triradiate cartilage, the lateral aspect of the triradiate cartilage. The medial aspect of the femoral head ossific nucleus is actually lateral to the lateral extent of the triradiate cartilage because it's an internal reference, right? And then the lateral edge of the acetabulum and lateral edge of the lateral edge of the ossific nucleus. These are the 5 areas that you will be looking at most commonly when you measure the migration percentage. So although the migration percentage is really one of the best measures for determining risk of further progression. And although I don't mention it in this talk, the head shaft angle is also another very important measurement that our Swedish colleagues have shown us is a predictor for subsequent displacement. And the Swedish group has actually put together a risk stratified score that incorporates GMFCS level, migration percentage, and the head shaft angle to come up with a risk for subsequent displacement over time. So as we start to think about studies that stratify risk of displacement, perhaps that study should be used as a way to determine baseline risk of displacement. Nonetheless, there are other radiographic signs that are relatively subtle that you can see on an X-ray here. The first is called the Brake-and-Shenton's line, which is a line that we draw between the superior aspect of the the inferior aspect of the pubic ramus and the inferior aspect of the femoral head. And on the patient's right hip, you can see it's intact. And on the patient's left hip, you can see that you can't draw that line without making a break. And this is an important part of talking about X-rays, which is that we always refer to X-rays as right hip and left hip in reference to what the patient's right and the patient's left is. So all X-rays are obtained as if we're looking at the patient. So the patient's left hip is to your right. The patient's right hip is to your left. So whenever I say left hip or right hip, it's always the patient's left hip or right hip, not what you see on the screen. So the first radiographic sign you see is a Brake-and-Shenton's line. The next is an increase in the acetabular slope. That's another subtle difference that you can see side to side here. An increased slope on the patient's left hip compared to a more normal slope on the patient's right hip. And then also a widened teardrop as well, where you have the normal concavity facing the femoral head on the patient's right hip, whereas on the patient's left hip, it's widened and a little bit more convex. You can't really make decisions. You can make surgical decisions based on these more subtle differences, but it can also cue you in for migration percentage because these differences on the X-ray go hand in hand with migration percentage increases. As you can see, the X-ray on the left-hand side has a lower migration percentage than the one, the patient's right has a lower migration percentage than the patient's left hip. So the migration percentage is really is reliable, and the way you measure this is you draw a horizontal line that levels the pelvis, and then you draw 3 vertical lines that correspond to important landmarks that I'll teach you. So first step in migration percentage measurement is confirming that you have a properly positioned AP pelvis X-ray. We talked about this earlier, about the way that a child should be positioned with neutral leg abduction, with the pelvis horizontal, with pillows underneath the legs to make sure that the pelvis doesn't tilt anteriorly so that you have a proper view of the pelvis. And a properly positioned pelvis should look like this, with symmetric pelvic wings, symmetric and oval obturator foramina, and a hip that is in neutral abduction-adduction, is not way out or way in relation to the child. A leg that is in severe abduction will reduce the migration percentage because now you're pointing the hip towards the socket. A hip that's in severe adduction will increase the migration percentage. And both of those are artificial measurements. So we have to sort of decide what our starting point is. And our starting point is a neutral hip to sort of describe across patients. We went over these earlier. In the example that's to your left, symmetric pelvic wings, symmetric obturator foramina, and femora that are in neutral. And here we have an asymmetric pelvic wings and obturator foramina and femora that are abducted in the middle example. And in the example on the far right, obturator foramina that are not visible, difficult to visualize, and femora that are abducted. So we want to aim for this. This is not in your control when you are analyzing an X-ray, but by being aware of this, you can then say whether you think that it's an accurate assessment of the migration percentage. So it's important that the first step you do is it an adequate X-ray? Step 2 is establishing the horizontal axis by which you're going to measure the migration. Children do not show up on the X-ray unit perfectly perpendicular to the horizon, and that and few ever do. Okay, so you have to establish some landmark that establishes the horizontal. So you can choose any of these landmarks, and the closer you are to the hip, the more accurate your landmark assessment will be. So the triradiate cartilage is our preferred method of leveling the horizontal. So drawing a line that connects the same landmark on both sides of the pelvis for the triradiate cartilage. The next best is your acetabular teardrop, which is still pretty close. Next best is ischial tuberosity. And last best but not least is your iliac crest. Any of these will work. If the triradiate cartilage is closed and you can't see it anymore because the child is skeletally mature, then you have to rely on one of the other three landmarks. Step 3 is drawing 3 perpendicular lines for each hip. The first is drawn on the medialmost aspect of the ossific nucleus of the femoral head. The second is drawn perpendicular, like all these are perpendicular, are drawn at the lateral edge of the acetabulum. And the final and most lateral line is at the lateralmost edge of the ossific nucleus of the femoral head. Okay, and the same is repeated for the opposite hip. Once that's done, it's a simple ratio. The distance A is the distance of the femoral head that is outside the edge of the acetabulum, and distance B is the distance of the width of the entire femoral head. So it's A over B times 100 per hip. So here's some techniques to establish the horizontal line, because it sometimes can be a little bit difficult. The example on your left is an example where it's relatively easy to identify that triradiate cartilage. You can see it's a nice line, like dark line. So it'd be fairly easy to be consistent about choosing the same landmark on both sides of the pelvis to draw your horizontal. Well, what about that example on your right, where you can kind of see the beginning of it, but it's sort of overlapped. It's a little bit more difficult. Interestingly, it's also in a child that has a more severely dysplastic hip on one side, so that shouldn't come as a surprise that it's harder to position children who have hip dysplasia. Well, one thing you can do is, so it's easy on this side. On this side, you can draw your line and then double check it against another landmark. So look at another landmark and make sure that the lines are relatively parallel. And then you have an internal check. Okay, that can be done with the acetabular teardrops. It can be done with the ischial tuberosities. It can be done with the pelvic wings if you can see them. In this example, you can't see them. Another trick is to help the sourcile lead you towards the edge of the lateral edge of the triradiate. So here's the sourcile, and right where the sourcile intersects the triradiate cartilage, you would be relatively confident that it's the same landmark on both sides. Okay? And then you would double check it against another landmark if you're unclear. Okay, now on to the femoral head landmarks. This is a child that has a severe coxavalga, a femur, now that you've seen a few, that is pointing straight up. And look at the direction of that growth plate. It should be, the 90-degree angle to the growth plate should be pointing towards the triradiate cartilage. It is pointed in the exact opposite direction. So this is a child that by the Swedish criteria of head-shaft angle would be immediately identified as a child with a very high risk of subsequent dislocation in the next 2 to 3 years. And this was the example that I showed you that over 2 years dislocated very rapidly. So one thing you'll notice if you look very closely is that the width of the femoral neck here with the black arrows is very different than the width of the ossific nucleus of the femoral head. The reason we choose the ossific nucleus of the femoral head is because that is what ends up being the cartilage of the hip socket, not the width of the femoral neck. So the medial and lateral aspects of the ossific nucleus of the femoral head, represented here with the solid lines, black for medial, white for lateral, should be used as the landmarks for the medial and lateral aspects, not the dotted lines which are corresponding to the femoral neck width. Okay, that's important because you'll see that pretty commonly. We have recognized in our group after doing a few of these validation studies that most of the variability in choosing landmarks lies in the acetabulum. And there's a tremendous variability. Here are 4 patients, each with very different acetabulae. the image that's going from left to right, the leftmost one is a very sharp sourcil with a very easy to identify edge. The next over, the sourcil goes up and then comes back down. So do you choose, where do you choose it? The following one, it doesn't even have much of a sourcil, but you can identify a relatively sharp edge. And the final one on the right, it's very hard to see much of anything. So we think that the sourcil is a very important landmark. And so that should be part of identifying the lateral edge. So first thing is to look for your sourcil. And then the second step is to identify what appears to be the bony edge. Now in this case, the sourcil goes all the way up to the bony edge, but in some cases it doesn't. So we came up with a little, and there's one other thing I want to show you about the variability in sourcil. In some cases, you may have what's called a Gothic arch appearance of the edge, which is an upturning at the edge of the acetabulum. And that's due to early dysplasia. Whereas the normal will be more of your eyebrow appearance, the Gothic arch would look more like a troubled or a surprised eyebrow. So this is an algorithm that we created locally to try to help us be consistent about choosing what is our lateral acetabular edge. And it incorporates identifying the sourcil, seeing if there's a Gothic arch, and seeing if the lateral edge of the acetabulum is clearly identifiable. And with those three questions, so to speak, you can kind of head down a certain path. So let's go down each of these paths. In the first path, you have a sourcil where the entire sourcil is clearly identifiable all the way to the edge of the bony edge of the acetabulum. So that's your most common case in an early child that has very little dysplasia. And a Gothic arch in this case would likely not be visible because Gothic arches are more visible in more severe dysplasia. And so you would use the edge of the acetabulum because it's very easy to choose and very reliable. And that's shown by the red X there. The image above just shows it without the overlay, and then the image below showing you kind of a little bullseye as to where the edge should be measured from. In the second case, you have a Gothic arch. You have a sourcil that goes up and then comes back down. It's been recognized in studies that this correlates to early dysplasia, and by using the lateral edge of the acetabulum, the bony edge, you probably underestimate the true amount of dysplasia. So the more accurate way is to use the apex, or the very top of the Gothic arch, the ceiling, as your lateral edge. That is not the same as the lateral bony edge in this case. So that's an important distinction. That will increase the migration percentage measurement, often to the point that you refer them, because these Gothic arches are probably not as frequently seen when the migration percentage is well below 30%. You can see how in this case it changes the migration percentage from somewhere around 50% to almost 75%. But there will be cases that you will see where it changes the migration percentage from under 20 to over 30. And that's where those are the cases where it's important to pick out this landmark. In some cases, you will not be able to clearly identify the sourcil going all the way out to the lateral edge. In this example, there's really no clear sourcil. There's a hint of a Gothic arch, but you can't really see a sharp line. And in that case, you just use the lateral edge of the acetabulum. That's probably the most reliable, because you'd really be grasping at straws to figure out where the apex of an invisible line is, right? Finally, there are some cases in which you don't have a sourcil. It's really hard to identify a lateral edge, and you just have to use your clinical judgment as to what you're going to call the edge of the socket. And those are the most challenging cases. Okay, let's go through the migration percentage ruler and how it's used. So I'll go through an example with you, and then we'll actually do it live. We'll go through the 4 examples, and I'll go through it with you, including how to manipulate the images, and I'll try my best to meet every one of you where you are, just like a good elementary school teacher. As I've had young kids, I've seen how ridiculous it is to have huge class sizes and one teacher trying to meet everybody's needs, right? But go figure. So the migration percentage ruler, what you'll do is you will choose the migration percentage ruler on the main screen, and then you'll have an opportunity to take an X-ray of your of the sheets right in front of you. And then you'll do that by selecting the camera icon. When you first load up the app, there'll be a little disclaimer about not photographing any patient-sensitive stuff, which this has all been de-identified. And also it'll ask you to access your camera. Fear not, nobody is looking in on you. It's merely allowing the app to use your camera to take a picture of the X-ray, which will not be stored on your device. Once you take the X-ray, you can then pan and scroll and then rotate the image using the rotate tool. So there's this counterclockwise and clockwise buttons that you can rotate it, and you can pan it so that these horizontal lines go over the areas that I described to you earlier, which are the triradiate cartilage, ischial tuberosity, the acetabular teardrop, or iliac crest. And you can move the image until you're confident that the pelvis is leveled. Once this is done, you then press the Done button, and you can then press the ruler button, and you'll get a ruler overlay that lays over the image. And I'd like to go through this ruler overlay with you and how it works. I'm going to have some of you eager beavers just take a pause here and just watch this whole. I see some people taking photos, which is wonderful. I love the enthusiasm, but there's some little parts that are a little buggy that you might want to just kind of stay tuned for. So just look up at the screen. I love the enthusiasm. Okay, so we're going to be using the way this ruler works is it's dividing the screen in half, and you're going to then zoom the image of the right hip for this half of the ruler, and then you'll use the other half of the ruler for the left hip. Okay, that's important because if you try to flip-flop them, it doesn't quite work. So what you end up doing is once the pelvis is leveled, you now zoom the image until it fits appropriately on this ruler. And the appropriate way it fits is that the white line should touch the lateral edge of the femoral head ossific nucleus. The black line should touch the medial margin of the femoral head ossific nucleus. And now, once this is done, although these numbers will not appear on the top, the femoral head has been divided into 10% increments by vertical lines. Right? So now we've taken the whole measurement thing out of the picture. Essentially, now what you have to do is just figure out what percentage of the femoral head is outside the edge of the acetabulum. And so you do that by identifying the location of the edge of the acetabulum and recognizing that it's the first, second, third, fourth vertical line from the edge of the screen. And so 40% of the femoral head is outside of the socket. So no measuring, no moving, and frankly, pretty easy, right? And it's not that hard to do. A step easier, you don't even have to count. You just have to look. Is the edge of the socket inside this red box? The answer to that is yes. The migration percentage is over 30%, regardless of whether you're on the right side of the screen or the left-hand side of the screen, because we've connected the sort of danger zone areas to create the red box. If it's outside of the red box, it's under 30%. That's it. So you don't need to measure. So if you want to get quantitative, you can. We found in our initial studies at our institution that it's as accurate for quantification as the fully functional PAC system and almost as fast, within 10 seconds of what it takes you to do it on a fully functional system. But even easier for a screening program is to just decide in or out. That's much easier. Okay, so here's some examples of what it looks like. The edge of the socket you see here, the edge of the acetabulum you see here with the yellow arrow, and you see here it's outside 10, 20 line, and it's between the 10 and 20 lines, so it's 15%. Here's an example at 30, 10, 20, 30, exactly is over the red line. Okay, so it's 30%. Here's a 50% example, 10, 20, 30, 40, 50. And it's right at the edge of 50, okay? So it's pretty easy to determine, and it's going to depend on the quality of the photo that you take. So this copy of a copy of a copy that you have in front of you may not be as accurate, but it'll give you some overall guidelines about how to do things, okay? Okay, so now it's your turn. I'm going to do this live with you. So so maybe just bear with me for the first one, if you wouldn't mind kind of going along with me. Is that okay? All right, so here we go. So we're going to start with example 1. And I'm going to see there is... Let's see. All right. So, okay, so what I'm going to do is I'm going to try to do something fancy here. Okay. Let's see if this fanciness works, or, oh, it's going to work. Oh, yeah. Okay, here we go. All right, so this is my kid's drawing. Sorry. That's supposed to be me. Let's see if I can get this to work. Okay. Okay, so the first thing you're going to do is go to your migration percentage ruler and select the migration percentage ruler. Okay, once that's done, business here. Okay, the next thing is you're going to take a photo, and you're going to do it in a very specific way. You are going to help your partner take the photo. Okay, so one of you, pick a friend, and one of you hold up the x-ray, and the other one take a picture. And then flip-flop. That's important because there's a little bug in the program that doesn't allow you to do, exactly, it doesn't allow you to do portrait mode. It needs to be taken in landscape mode. Okay? So if any of you have tried it already because you're so eager, now you know. Okay, so I'm going to load up this x-ray. Okay, so here we are. Once most of you have gotten it, try to zoom in as much as you can to the x-ray to really get it there. I'll give you a minute or two here to get that going. Okay, now that you all have completed this course, almost, raise your hand if you think that the migration percentage of the patient's right hip, oh no, how about this? Raise your hand if you think this patient needs a referral to a pediatric center. Okay, good. So your eye can see it pretty obviously, right? Yeah. So in that case, you probably don't need to measure this, but once it gets, but it is good for quantification, so we'll go through the exercise of quantifying it. But all of you, raise your hand if you think that the left hip is the problem hip. No. Raise your hand if you think the right hip is the problem hip. Yes. Okay, good. Yes. All right. You don't need this app. Okay. So you can see you can zoom in. Okay, you can zoom in on things. And then you're going to press the rotate button. How many of you are not on this step yet to be able to do rotate button and stuff? Okay. Have a friend hold it up for you. Take a picture. Okay, another important thing. If you're going to retake a picture, please press this done button in the corner and go through the whole thing again. There's another little bug in here that ends up corrupting the app if you try to retake the photo within the same session. We're still working on it. Like on the bottom row, you'll see like things kind of off center and it like doesn't work anymore. You have to close the app and reopen it. So some of you may have experienced that as well. So every time you shoot a new X-ray, just hit the done button. I'm learning that with software development, bug fixes are the name of the game. I'm not a software developer type. Okay, so I'm going to load up that X-ray one more time, and then I'm going to go through the full deal with you guys. Okay, great. So first step is to rotate the X-ray. So go ahead and zoom in on it. I find it helpful to zoom in till you can, till the trirated cartilage is pretty well visualized. And then you press the rotate button. And then you can use the clockwise and counterclockwise buttons to rotate it. So I'm kind of over-rotating it in the counterclockwise way, rotating it in the clockwise way, okay? The reason we decided to not make this just a pinch and rotate thing is that pinch and rotate isn't very sensitive, and you end up kind of moving it without expecting it to. So one thing you can do is you can then zoom in further. And another little trick is to turn the overlay on and off. So if you kind of turn it on and off, sometimes that can help you see it. You can use different lines for different landmarks. So for example, I'm using the third from the top line to see if it matches up with the acetabular teardrops. I can even go to the bottom and see if it lines up. The bottom line lines up with the ischial tuberosities. Because all of these lines are parallel, you can use any of them to level the pelvis. I'll give you a few minutes to do that. Okay, next step is to hit done once it's been leveled out. And at this point, you press the ruler button, which now has the ruler overlay. Okay? It will not rotate at all, but you can still pan and zoom, which is what you want to do. So let's start with the patient's right hip. So we're going to zoom, and as you zoom, you can move too. Okay? And you want to zoom it in a way that you can see all of the landmarks on that single screen. So zoom it to the point that the lateral edge of the acetabulum is still visible up at the top of the screen. So this is maybe about right. Another trick is you can turn the ruler on and off, and that can kind of better give you a sense of the landmarks. Okay? So here, now that it's all on there, the lateral edge of the ossific nucleus has a white line against it. The medial aspect of the femoral head has a black line against it. And we're going to then assess the position of the lateral edge of the acetabulum. Okay, show of hands as to measuring this. Migration percentage, who wants to say it is 50%? Raise your hand for 50%. Going once, going twice. 60%. We have some takers for 60. 65. 65. 68. Do we have 68? Okay. As any good elementary science teacher will tell you, your ability to discriminate is only as good as halfway between your two markers, right? So we think that this is probably good to 5%. Probably, I mean, you can probably say, plus or minus 2. It's not going to be down to 1. But 5% is all you need. And it's probably going to be, 30% is the vertical red line, 40, 50, 60. It might touch it. 70 might be a little bit too much. It's between 60 and 70, right? It's not bad. Okay, let's check the other side now. Okay, who in this room said that the left hip was not a problem? Okay, it's all relative. Yeah, it's not as much of a problem. Well, it turns out that if you measure the migration percentage on the left hip, it looks deceivingly normal, but it's 30, right? So, or close to 30, depending on how you measure it. So this, again, highlights the real importance of actual measurement of migration percentage. Because you can easily, if you leave this session and say that my eye is good enough, I don't need to measure, you'll end up missing a lot of children who are right at that threshold that actually need close scrutiny. Okay, good. Should we go on to number 2? Okay, here we are with example number 2. Are people far enough to have taken pictures? Okay, how about this? Let's, to prevent fatigue, and I recognize that your copies are not really high quality, so that's part of the problem. How about I go through a few examples, and I will set it up, and you guys can take a look and measure it, so that you feel relatively confident. I can kind of talk you through it. If you wanna actually take the picture and measure it, you can feel free. I don't want to prevent any enthusiasts. So here, press the rotate tool. I'm leveling the pelvis here. Applying the ruler overlay. Okay. So this hip, the patient's right hip, the patient's right hip is right at 30%. Okay. And let's see the other side. So here on this side, it's a little bit more difficult to figure out exactly what is the edge, anyways. It's certainly, there's no bony edge that's really convincingly less than 30. And then depending on what landmark you use, you could be 30, 40, or even 50, but certainly above 30, right? So I think you'd have to have sort of a consensus conference to decide exactly what the migration percentage is, but certainly of concern still. Okay, let's go to example number 3. Actually, let's go to example number 4. We'll do number 4 now. Before we do anything else, take a look at the morphology of the acetabulum in this case. Does it look like a well-manicured eyebrow? No. Looks like my eyebrows. No, I'm just kidding. No, it is not well manicured. So this is a Gothic arch type of appearance. Okay, so as we do this and rotate it, this is example number 4. Did 4 get emitted? Oh, I just gave you the ruler? Oh, sorry. Okay, well then we'll do the steps here and I can go through it. And then we can go through maybe example number 5 as our final one. Okay, so here I'm rotating it. And now applying the ruler. And here you can see if you take the lateral edge of the acetabulum, it's probably somewhere around 25. So just between the 20 and the 30 vertical line. But if you take that apex of the Gothic arch, it's closer to 40, right? So this is an example where the child would have probably had a difference in referral pattern dependent upon where you define the lateral edge of the acetabulum. Yeah, so if you, so the question was, can I show you the Gothic arch? And I can. As you go from, oh, actually, I can use the arrow. That'd be better. So the way that you measure this is 0, 10, 20, 30, 40, okay? And if you start from here, it's probably best if I just take this off for a minute. You see the acetabulum go slope up and then come back down. There's an area where it kind of goes up even higher over here. But the apex is in here, in this area. So when you put the ruler on, it's closer to 40 than it is 25. Does that make sense? Okay. Good, and then we'll go to the other side, which is a more normal appearing hip. And here's another good example of some differences in the morphology of the proximal femur. You see that if you follow the ossific nucleus, it goes like this. All the way, there's a little divot, which is where the ligamentum teres inserts. And then the ossific nucleus comes all the way down to here. So it comes all the way down to here. So when you actually put the ruler on top of it, it's that medial aspect is more medial than you would think if you didn't recognize that it goes all the way down. And to be able to identify that, the landmark is really the growth plate here. You see this black line going all the way out to here. So you want to follow that black line and make sure that you don't, so that the medial aspect of the femoral head goes all the way. So in this case, clearly the lateral edge of the socket is closer to like 20 or 10%, between 10 and 20%, perhaps, but certainly much less than 30. Okay, who has the stomach for another one, or would you like to answer questions? More? All right, good. The front row wins. Okay, here we go. Everyone else is like, I'm hungry. Let me go. Okay, great. So we'll do the final example 5 together. Okay, so go ahead and take a picture. I'll give you a few moments to do that. What the two is? Oh, it's a shunt. Yeah, it's a VP shunt. VP shunt. Yeah, the kid has hydrocephalus. Yeah. We have some radiologists in the room who have identified a VP shunt on this patient. Well done. Orthopedic surgeons never see anything that is not metal or bone. So, so well done. Okay, great. So next you'll zoom in, rotate, and now I'm using the second line from the top to kind of find the same point on both aspects of the pelvis. And I'm going to double check my rotation against the teardrops, which it looks pretty good. Then I hit done. Once I'm done rotating, and then hit touch ruler. To do the ruler overlay, we'll start on the right hip. And And again, it's helpful to sometimes turn the ruler on and off just to make sure all of your landmarks are appropriate. Any volunteers for assessing the migration percentage? Loudly, please. 60. I would agree. So 30%, 40, 50, 60. 60% of the femoral head is outside the edge of the acetabulum. Good. Let's do the other side. The black line on the medial edge of the ossific nucleus, the white line on the lateral edge of the ossific nucleus. And then turning the ruler on and off is helpful. Any volunteers for assessing this? Any quantitative measurements? Hands for 80%? Hands for 85%? Hands for 87%. Okay, great. Certainly between 80 and 90. I think beyond that is probably up to speculation, but certainly like 85-ish, right? Referral. Okay, very good. So I hope that gives you a little taste of the app and what it can do. And I'm happy to take any and all questions now. Okay. Well, very good. Let me end the presentation here, at least the recorded portion, and then we'll